with the references. So for the fellows and whoever interested, you can catch these barcodes and references. Go ahead, Ahmed.
Assalamu alaikum. Hello, everybody. Today I'll present couple of interesting cases. I hope you do enjoy it and get benefit from them. Start with the case number 1. This is a 37-year-old female. She came with the outside report of left upper quadrant mass. They said it's query gist. So accordingly, the biphasic CT scan was done. I'll give you a couple of seconds to look at it before I start the polling. Okay, what do you think it's the most likely diagnosis? I'll give you 20 seconds to choose. Around 50% has voted. Okay, I'll end the poll here. So most of you have chosen infarcted splenial. Well, this case was challenging, so we did an MRI to make sure what the lesion was, and here you can see the MRI. The lesion is dark on T1, dark also on T2, with a central high signal on T2, which is indicating Mercedes sign. If we go back to the CT, you can see here there are surgical clips seen in the around the liver. We dig into the history. The patient has a prior cholecystectomy. Also, in the MRI, the images are not provided. There is no enhancement. So the overall findings are compatible with the dropped gallstone. The awareness of dropped gallstones is important because it may mimic other conditions such as peritoneal metastatic disease, or in our cases, it was query gist. The dropped gallstone occur in 30% of laparoscopic cholecystectomy. Only 3% of the dropped gallstone may subsequently develop an abscess. If the abscess occur, the dropped gallstone will be the focal point of infection. The abscess, it may occur days to years after cholecystectomy, and the patient who developed an abscess will continuously have recurrent abscess until the stone is removed. That's why it is important to know about the dropped gallstone, to aware the patient about it, and the physician has know the diagnosis about it. I would like you to refer to this article. You can scan this code by your mobile. It will get you to this article about foreign object encountered in the abdominal cavity on CT scan. Moving on to the second case. This is a 22-year-old female, medically free. She presented to the ER with diffuse abdominal pain. On the bedside ultrasound, they said they found a huge abdominal mass. So contrast enhanced CT scan was done. I'll give you a couple of seconds to look at it before launch the polling. Okay, what do you think the most likely diagnosis? Dr. Badr? Okay, I'll end the poll here.
Go ahead, ما في مشكلة.
So most of you have chosen an ovarian lymphoma. Okay, so as we can see here in this case, there is a large left adnexal mass. It is associated with left adrenal mass as well as retroperitoneal lymph nodes. The mass was resected and the pathology shows it's high-grade B-cell lymphoma. The lymphomatous involvement of the ovary usually secondary to systematic disseminated disease. Most common type involved the ovaries is the large B-cell lymphoma, as in our case. Usually it's bilateral homogeneous solid masses without calcification with mild enhancement. If it's in case the bowel, it doesn't cause a bowel obstruction. This is a companion case. Also, we can see here there is a large adnexal solid mass. It's in case the abdominal vasculature without invasion. Also, there is involvement of the liver, mediastinal lymph node, and chest wall. I would like to refer you to this article. It's a multimodality imaging approach to the ovarian neoplasm with pathological correlation. You can scan the code. This article has a ninth algorithm approach. You can read it. It will help you in differential diagnosis for indeterminate ovarian neoplasm. Case 3, this is the 39-year-old female presented with progressive severe left abdominal pain with weight loss. Contrast enhanced CT was done. I'll give you a couple of seconds to look at it. Okay, what's the most likely diagnosis? Okay, around 50% of the people have voted. I'll stop the polling. So most of you has chose that it's retroperitoneal lamp. A biopsy was done from this case and chose the diagnosis was Basidiobolomycosis. Basidiobolomycosis, it's rare fungal infection caused by Basidioblomus random. The abdominal involvement of it, it's uncommon and usually affect the young immunocompetent individual, particularly children. The typical involvement of it in the colon, small bowel, liver, or stomach, not usually involving the retroperitoneum. The diagnosis of it's difficult due to non-specific symptoms and radiological findings. If it's involved the GI tract, it may mimic malignancy, inflammatory bowel disease, or diverticulitis. The key laboratory findings is eosinophilia in the histopathological appearance of fungal hyphae surrounded by eosinophilia infiltration, mainly in individual from endemic areas. And this patient was treated successfully with antifungal agent without surgical intervention. This was a case report done in our hospital by Dr. Shirida, Dr. Mahalli, Dr. Shbeli, and Dr. Sahibani. You can scan the code, it will direct you there to the case report. Okay. Case number 4, this is a 40-year-old female with right lower abdominal pain. Outside ultrasound shows a large mass. I'll scroll through the images before I show the static image. And here is the static images. I'll give you a couple of seconds to look at it before launching the polling. Okay. So what's the most likely diagnosis? Okay, I'll stop the polling. So most of you have chose desmoid tumor followed by none of the above. Okay, the patient, she went for an MRI, which shows the lesion shows intermediate T2 signal intensity, diffuse restriction, and it has a zebra enhancement on arterial and became homogeneous on portovenous phase and delayed phase, which is follow the normal spleen enhancement. Also, the patient did a sulfur chloride nuclear scan, which shows avid enhancement. When we dig in the history, the patient had a history of trauma at age of 3 years, and then biopsy was done and shows a splenic tissue. The splenosis, as we know, it's heterotopic transplantation of splenic tissue. Although it's a benign condition, it may mimic malignancies. It usually occur after splenic rupture, either by trauma or iatrogenic. Usually, we see it in the abdomen, such as in the greater omentum or the bowel serosa. It can be found in the pancreas or in the pelvis. The unusual and rare locations, there are a couple of reports about liver involvement, also kidney involvement, and subcutaneous tissue. This is a nice article. You can scan the code. It's about the CT of splenosis patterns and pitfalls. Okay. Moving on, this is the case number 5. This 36-year-old female, single, medically free, complaining of menorrhagia. I'll show you the CT and MR together. I'll give you a couple of seconds to look at the CT before I go to the MRI. And this is the MRI of the case. So what do you think the most likely diagnosis? Okay, I'll stop the polling here. So most of you have chosen squamous cell cancer of the vagina, followed by rectal cyst, lymphoma, then none of the above. Well, this case was treated, biopsy was done. It was treated medically with surgical resection. And I'll show the MRI post-surgical resection you are after treatment. The biopsy was done of the case and shows it was an endometriosis, which is none of the above. Vaginal endometriosis, it usually involves the posterior cuff of the fornix. That's most common location. Usually results from inferior extension of retrocervical lesion. While chronic fibrotic endometrial implants are the typical in this location, polypoid mass may also be seen protruding into the posterior vaginal vortex, as of our case. The accurate diagnosis of vaginal endometriosis is important for surgical planning, because if it's inadequately treated, there is a high risk of post-surgical rectovaginal fistula formation. If there is full thickness vaginal involvement, then partial vaginectomy may be necessary. You can read more in this article about endometriosis MRI lexicon. Just scan the code, it will get you to the article. Okay, moving to the last case. This is a 29-year-old single female with chronic abdominal pain. Ultrasound was done by a gynecologist. It was not specific, so we moved to the MRI. This is the MRI of the patient. I'll give you a couple of seconds to look at it. Okay. So what do you think the most likely diagnosis? I'll stop the polling here. So most of you have showed accessory and cavitated uterine mass, followed by none of the above, then cystic adenomyosis. The result of this case appears to be, it was diagnosed with a cystic adenomyosis. Cystic adenomyosis is a rare variation of adenomyosis resulting from an extensive hemorrhage within the ectopic gland in the myometrium. It appears as endometrioma-like myometrial hemorrhagic cystic mass surrounded by adenomyotic tissue. It may be found any part in the uterus, including the myometrium, mucosa, and subserosal layer. The subserosal adenomyotic cystic may mimic an ovarian tumor. This is an article. You can scan the code to refer you about the adenomyosis, the usual and unusual imaging manifestation. And that was my presentation. Thanks to Dr. Badr Mutari for his great help. Also, special thanks to my consultants in KFMC, Dr. Dosari, Dr. Sharida Mazen, and Dr. Fahad. And special thanks to my colleague, Dr. Ahmed Mutari, for helping me in preparing the cases and presentation. Thank you so much.
يعطيك العافية أحمد. Very excellent presentation cases. The trick is the none of the above, huh? But when we choose none of the above, it turns to be cystic adenomyosis. طيب, we will allow some questions. I can see Dr. Fawaz Al-Harbi raising his hand. Go ahead, Dr. Fawaz.
السلام عليكم. مساء الخير. شكرا دكتور.
السلام ورحمة الله. حياك الله.
دكتور شكرا للفيلوز for these interesting cases. أعتقد إنه the good title for tonight's interesting cases is the sheep in wolf clothing.
Yes.
They look malignant, but they tend to be benign, whether it is IG4 disease, drop gallstone, or the splenosis, ولا polypoid vaginal endometriosis, ولا adenomyosis. أعتقد الشباب كلهم متفقين اليوم على المبدأ هذا. بالنسبة لل IG4 صراحة I find it the focal pancreatitis و IG4 one of the challenging diagnosis. So sometimes we play the Superman and call it cancer and tends to be cancer IG4. We do also vice versa. Sometimes we play the Superman saying it's IG4 and then it tend to be cancer. It's not easy. The more you read, the more you get confused. And when you read it in the literature, they give you really good numbers, excellent cases, nice cases, but the real life is completely different. So I think if there is anything that's fishy in the case, it's probably wise not to play the Superman and say, okay, this probably this or this. I can't say it for sure. I remember playing the Superman for one case and then it didn't turn well. So I guess the literature and most of the studies, if you read the literature, most of the studies are retrospective, which tell you something. It tells you it's not that easy, and it's difficult to stick your neck in prospective study and say this is just IG4. Forget about it. Just start steroid, and be aware that most of the time when you say steroid therapy trial, most of the surgeons they are reluctant actually to start the steroid therapy because they think if it is cancer, steroid therapy will just make it worse. So they probably rather do biopsy or go for surgery rather than probably going for steroid. And that's just my limited experience. Probably the others have